I think we should probably start because Steve does tend to go on a fair bit. So this is the second session of the musculoskeletal segment on Spec CT. If anybody's lost and thinks this is about PET, you should bugger off. I'll start by introducing Steve Allwright. Now, Steve's not as young as he looks. He's been around a very long time. As a matter of fact, Bob Cooper, Steve Allwright, Jock Anderson, and Ken Crichton were some of the pioneers of nuclear medicine involved in sports medicine. And we owe them a great debt of gratitude because it disseminated fairly quickly. They've taught all of us a great deal. And I think Steve's a bit lost. He's talking about how you assess a painful hip prosthesis. So without further ado, Steve Allwright.
And thank you for those very kind words. I haven't actually got my hips in yet, but they'll probably come. And I'd also like to thank the organising committee for asking me to speak and for a whole lot of people to turn up, which is very nice. Thank you. Let's just try that. Oh, it's gone one too far. First of all, disclosure. I've got no financial disclosure other than a large mortgage, but you don't need to know that. But scientifically, I'd like to preface it by saying there's very little science in this talk, okay? I've just worked at a hospital that I'm told does more joint replacement surgery than any other hospital in the Southern Hemisphere. And because of that, they've thrown cases at me over the years, and you think about it a bit. So this is purely anecdotal, my take on how I look at these. And your hospital and your surgeons may do different things, and that may change what your impression of how you look at it. But I'll give you my experience as much as I can. I'll throw in a little bit of brief history, and basically the first joint replacement surgery that I could really find decent history for was this Gluck back in the 1980s. Sorry, the 1890s, that should read. 1890s, I can't type. And he put in ivory in a whole lot of joints. And they did okay for a while, but they almost all failed. But that was because most of them were tuberculous joints. And not surprisingly, the infection came back. People then went on to do a whole lot of things, particularly these putting in different tissues between the hip articulating surfaces, particularly pigs' bladders, which, I don't know, maybe it's a surgical thing. I don't know why you choose a pig's bladder. But then went on to, they tried a glass head, which was biocompatible and nice and smooth relatively, but it shattered. And interestingly, they then went on to try stainless steel back in 1925. And then in 1953, this English surgeon took a hemiarthroplasty that they'd been using before and created a head and had a metal-on-metal prosthesis, which had good results, except that when they did revision surgery, they found a whole lot of metal particles, which amazed me when I found this, that you sort of think, well, don't we learn anything from history when you think about the current controversy with metal-on-metal prostheses. But the real father of modern surgery is Charnley. Did the let's see if I can get this to work. The three-component of femoral head and a liner that is really the father of what we do today. It has gone on to all sorts of other things, from polyethylene liners. They've got high wear problems, so then they've done this cross-linked polyethylene that's supposed to have less wear. Metal on metal, ceramic. Problems with the ceramic is it's nice and smooth and it's really strong, but it tends to shatter as well, a bit like the glass ones sometimes. And it's not just the heads. There's all sorts of shafts. And the difficulty with this is, depending on what's in there, it's going to change what the scan looks like. And so you sort of need to know what you're dealing with. And you can see on these shafts, some have got bits to... does that? Yeah, it does. Some have got hydroxyapatite and various beading to make them stick in. Some are just straight in. Some are tapered. A lot of variations that we need to know about. And then, of course, there's a lot of them, these modular ones where they can adjust the angle and the length, but these all have their own interesting characteristics, and they solve some problems, but they tend to lead to other problems. Oh, wrong way. There we go. Okay, and then you've got, lastly, the hemiarthroplasties for fractured neck of femur, and more recent years the hip resurfacings, particularly the Birmingham's, which seem to be slowing down again. There was a real fad 5 years or so ago, but I'm not seeing quite as many now. The big benefit of these is you can go in later. You buy time in a younger patient, but you can go in later and do a hip prosthesis rather than having to do a redo on someone you've already done before, where it's much harder surgery. And then there's how is it put in, cemented, uncemented. In the early days, it was always said with cemented prostheses that they should be back to normal in a year. I don't think they all were, but most of them were. But then along came the uncementeds, and they've got ongoing bone ingrowth, and they can stay hot for a much longer time. I've never seen a really good article telling you how long it should be. People have said probably up to about 2 years you can have some activity. I suspect some can still have a little more after that. And that compares to knee prostheses, which Aaron gave a very good talk on yesterday, but they can stay warm, particularly on the blood pools, a high percentage for much longer time. And in fact, my partner in Merv Cross, who was sort of one of the fathers of knee prostheses in Australia, they did a study that on about 200 of the patients over 2 years in, and almost all of them had some activity around their knees, even when they were asymptomatic. Wrong way again, sorry about that. And then there's also how they put in, what angle the cup goes in. So if they put it in at a very steep angle, they tend to dislocate easy, and you can see there'll be a lot of pressure up the top. If they, you should never see one of those. They should be diagnosed before you get to us. If they're very flat angle, they're usually stable, but as they abduct their leg, they can impinge there, and they have restricted range of movement. And then, this is what we so often see, and that's why you need to know what is in there. You may have screw loosening of one or more screws. There may be no screws. There may be lucency down the shaft here. There's a fracture down here. There may be complications from the circular wires. You've got to know what you're dealing with. And that's where SPECT-CT particularly has been fantastic for us, because so often we didn't get the x-rays. We didn't know what was there. So how good are they? In Australia, we've been very lucky. They started this joint replacement registry back in '99, and they put out publications periodically on how they're going. And they're now up to just over 500,000 hips. Last year, there were another 47,000 added, so that sort of gives you an idea of how many we're doing in Australia. And it's growing. Since last year, it had grown 73% since 2003, the number at the yearly annual thing. So it's constantly growing. Most of them being conventional ones, only a small percentage being the resurfacing. But the good news is the revision rate, which is really that guide to how they're doing, is falling. So while the number's going up, revision rate's falling to that. And that's estimated to be, like in 2016, that many fewer people needing revision, which is a huge cost saving, hundreds of millions of dollars, let alone the patient benefit. Against that, when they looked at the 10-year revision rate, taking all sort of combinations of all types of hip replacements, there's a huge range from as low as in some combinations of hip prostheses, 2%, right up to almost 50%, particularly on those big metal and metal ones. They generally take 5% sort of as an accepted revision rate, but only about less than half of them actually reach that 5%. So they're still they've improved dramatically, but there's still a lot of problems going on. And what are the problems? Well, the big ones we get asked for are loosening and infection, but there's a whole lot of other things you can find in there. And the bone scan is great for looking for all these things, but it ain't easy. After all the years, there's still a high percentage that are difficult. And I think the orthopods use it largely to, if it's normal, they won't worry about it, but if it's abnormal, they don't always believe what we say, whether it's infected, loose, stress fractured or what. But the other great thing about SPECT-CT is we can also pick at the same time the non-hip causes of the pain they're getting as well. So when I look at the patient, there's a few things I really want to know, and obviously the first thing you've got to know is how long it's been in there. And it's also good to know if there are any early complications, and if they've got a post-operative wound infection and 2 years later they're query infection, it pushes the rate up a lot. Have they had any injury, or have they been doing anything different lately is really important. And I find it also very useful to know whether it's been grumbling along ever since it went in, or it's steadily getting worse over the last month or two. It can change the outcome of the scan results quite a lot. It's also really important to know where the pain is. You get the request, hip pain. Hip pain can be there, can be there, can be there, can be there. And the position of it can greatly change again, what you're looking for. There's a whole lot of techniques. Plain x-ray is obviously important, looking for lucent lines around the prosthesis and the prosthesis position. Has it migrated over time? CT and MR can be useful, but the metal artefact causes problems. Metal suppression can help. Ultrasound can pick soft tissue pathology around it. But we've got quite a lot of range of things we can do in nukes. I'm going to concentrate mainly on the bone scan, but I'll talk briefly about the others. Wrong way again, sorry. When I started, I always really liked the fact that nuclear medicine was physiology, and that made it really sensitive. And I always thought, physiology is much sexier than anatomy. SPECT-CT, though, has really combined the two. We've really got the huge benefit now of both the anatomy and the physiology. It's been a great benefit. When we do our bone scan, we always do three-phase, and the blood pools, I think, are absolutely critical. I think it's very hard to diagnose and differentiate a lot of the things without blood pools. The delayeds, I think it's really important to do planars, good position planars. SPECT-CT is fantastic, but planars give you a whole look at the relative intensity over places, and the distribution often much better. As my partner, Bob Cooper, said famously for many years, and many of the people in the audience would have heard him say it, the bone scan's sensitive but not specific. And so it's good at picking up if there's something going on. It's not so good necessarily at telling you what it is. But pattern recognition, you can, it brings a lot of specificity to it. And the other thing about the bone scan is being able to look at the whole area gives you that chance of picking up pathology that's referred pain. Positioning, these are very old slides, but the two things that if you've got a gamma camera that's heads will tilt, then tilt the head and get it in close. I'm sure we've all seen, the patient with the big gut, but when the head's horizontal, you're 6-9 inches away from the hips when you're imaging them. The pictures are blurry. The other thing that I've always thought was pretty critical is getting the feet in the right position, which for me is the toes in together, the heels out. And what that does is it puts the hips out so you see the greater trochanters. You need to be symmetrical so you can judge side to side, but you want to get those trochanters out so you can really judge the whole hip, look for the things affecting the trochanters as well as the femoral heads. SPECT-CT, as I say, I think has been fantastic. You get that 3D view so you can get a much better idea. If you just look from above, you can look like anything sometimes. But the other thing that I think is really critical is rather than sort of trying to jump to a diagnosis, think biomechanically. And I'll just show a case in a moment. The reason for that is you've got to understand where the stresses are. What we're seeing on the bone scan to a large extent is stress on the bone causing bony response. And I'm just going to show briefly a case that I think exemplifies this. It's actually a knee case. But this was a girl who had a Ewing sarcoma removed from a proximal tibia, doing really well. About 9 months later, she started getting pain. Blood pool shows this activity down here. Is it recurrent tumour, infection, fracture, or what? The SPECT-CT, you can see this very hot area here. And if you might notice, there's this dark line through there. There's this bossing around the edge there, and there's a stress fracture through there. And what's happening here is if you look at she's got this funny prosthesis in here. The shaft, all the weight's been taken down here, and it's impacting on the cortex there, and she's getting impingement of that cortex. And if you compare it, when we look at it biomechanically, this whole bit of prosthesis is not supported, is not resting on anything. So all the weight's transmitting down there and fulcruming off this lateral tibial plateau screw. And so we're getting bony activity around the screw. We're getting a stress fracture down there. She needs to stop doing as much exercise because she's feeling so good and let it settle. But thinking biomechanically, you can work out what the hell's going on so often. Fractures, we see a reasonable number of these. It's decreasing. I think they're modifying the prostheses. Typically on fractures, you'll usually get some blood pool activity, not always, but mostly. And you can see here a hot spot in the medial femoral neck. If you look at the SPECT CT, and you can see this prosthesis has got a step in it, and right around the level of the step, we're getting stress on the bone there. That's a stress fracture. And the reason is, you can see this sort of step there. There's a thing called modulus mismatch, which you may have heard of. And what that is there's a mismatch between the stiffness of the bone and the stiffness of the prosthesis. And the prosthesis is really stiff. When there's stress on it, the bone's trying to flex, the prosthesis is flexing at a different rate, and you're not distributing the stresses through it evenly. And it can commonly lead to a stress fracture. Just to show that it's not a fluke, another one, exactly the same, similar prosthesis. And that's what I say about it. It's why it's important to know what the prosthesis looks like. And finally, a third case, a bit more severe sort of one. But the proximal ones are quite common. You can get them distally as well, but the proximal ones are common. And you can, if you rack your CT windows down, you can often see a fracture line, but not always. Again, the end isn't only the prosthesis that the bone that fails. Sometimes the prosthesis can really fail. But again, you shouldn't see these. They should have had an X-ray before they ever got to. And it's not just the femoral component. Here, this lady's getting pain. Sorry, up here, there's a little bit of asymmetry. It's not easy to see on the posterior on the right there, and there's a hot area in the acetabulum. And particularly if the cups are placed very close to the medial wall of the pelvis there, they can stress fracture through, or if they fall, it can very easily get a protrusio sort of one. That's a fairly obvious one, but the great benefit of the SPECT CT is you can pick up the subtle ones as well. And so this was a 74-year-old lady with a fall. You look at that and you look, the acetabulum's maybe a tad warm. You look at the SPECT CT images and yeah, there is a little bit there. And if I mag that up, you can actually see on the CT, low-dose CT, there's a small fracture line through there, which wasn't called by the earlier imaging. And so that's where I think SPECT CT brings a huge increase in the sensitivity for detecting these sort of things, as well as the specificity. It's not only the full prostheses, the Birminghams, the resurfacings, we have found quite an incidence of stress fracture in these. And again, typically, they have the surgery, they're doing really well, they increase their level of activity, and they stress fracture. And what happens is you've got this thinner bit of bone under here where it's being put in, and they stress fracture across there, and it's typically as they increase their level of activity. Another one, same sort of thing. You know, as I say, it's really not that uncommon in the more active patients. And again, on the SPECT CT, you can see this activity across the neck there. End stage of a stress fracture is a completed fracture, so you want to pick them up early. The one little proviso is I almost got caught once. This is an old slide, but it looks for all the world a bit like a stress fracture in a Birmingham's, but there's no hip in there. That's just an AVN on a fractured neck of femur. But if you haven't got a good historian, and that's again where the CT part helps you. And of course, we've all seen lots of query fractures that are in fact pelvic fractures, and always have a good look at the pelvis. If the bladder's big, as it often is in these people with painful hips, you know, again, the SPECT CT, at least if you can't empty your bladder, you can get a better look at the pubic rami and exclude fractures. And one of the other things is this one I thought looked like sorry, mouse is very sensitive. I thought this looked like a fracture, high blood pool activity, a lot of uptake over the greater trochanter, bit down here, but when you looked at the whole body, was myeloma. And so I think it is one of the other benefits I said before is that you can look over a wide area. You know, how far and who do you scan? It's always difficult. You know, the government doesn't want you scanning the whole body and charging for whole body scans. But at the same time, you don't want to miss things. So I think it's always, at the very, very least, I think you need to have got good lumbar, pelvis down to knees, and at the very low suspicion of something different, and particularly in the older patients, sometimes the whole body. Stress shielding is probably just another concept you should be aware of in relation to these. And what that is you can get the situation where all the weight's coming down here and is being transmitted into the femur down here. This bit of femur is bearing almost no force when the patient's standing and walking, and you tend to get this resorption in here as one of the causes of osteolysis, and that resorption can get to the point of being painful and stressed, and you can get a stress fracture in there. So if you see activity in that area, think of it as one of the causes of stress fracture. And you can see down on this case, there's a lot of thickening down in the shaft. But on the bone scan, you'll see activity in there, particularly on the medial edge, much more so than the lateral edge because there's a lot more force being transmitted laterally. Osteolysis, as I say, that's one of the causes. Probably the commonest cause is particle wear. From the polyethylene particles will lead to wear there, and you'll get increased uptake, again, proximally around there. In extreme cases, it may come all the way down, and you've got a completely loose prosthesis. In the earlier cases, it may just be bone resorption and stress reaction in there. That can look like that, with uptake proximally around the neck. In that calcar region is the commonest thing, not much at the tip. Oh yeah, osteolysis. I'll briefly show, this is one of you, not your case, but a knee case, just to show a more extreme example of what you can get if you get really bad. This was a patient, I thought, on the blood pool, and this it might be infected on this knee prosthesis. Very hot on the delayed pictures, and you look at the CT, eaten out hugely, and I thought this was going to be infection. The gallium scan, very underwhelming, and that's just particle wear osteolysis in under that prosthesis. You can get similar things on the hips, but usually not quite as bad as that. Tip impingement is another one that is very important, and we see quite commonly. If you see a little bit of activity at the tip, it's really common, but if it's central, it's usually fine. If it's asymmetric and more intense, then I think that's quite a common thing. And what happens is you get this pressure out here. It sort of migrates out and puts pressure usually on the lateral cortex, and they go on to get a stress fracture there. If you've got activity proximally as well, then the thing's probably loose, but sometimes you see it just at the tip. How you don't get loosening at the top, I don't know, but often it's just at the tip, and the CT is in combination with it is the guide to it. You'll get this sort of activity here, and you can see there's activity at the tip laterally. In their mild cases like that, it doesn't have to be gone into a stress fracture. The thing about these is they almost always complain of thigh pain. They never complain of hip pain. It's always, oh, the pain's down here. And as soon as you hear that, have a really good look at the tip. You can also get it with shoulder prostheses as well, and those reverse shoulder ones. Loosening, I think very difficult. Usually blood pools are normal. The femoral component, I think you typically see that uptake at the calcar region, like I just showed with the osteolysis, and usually also at the tip. And I've just always imagined biomechanically that you've got this thing jiggling around there, and the impact points are at the tip and at the top. Severe cases, you may get it all the way around, but once I start seeing it all the way around, I get suspicious more for infection. And we should be picking it up generally before they're really severe. The other one is the acetabular loosening. I think if you've just got activity at the top of the acetabulum, then that's usually just compressive stress reaction. They've often got, soft bone from all the osteoarthritis before their surgery, and if they load up there, they can just squash that up. If it's loose, it's usually all the way around the acetabulum, because you can just imagine the cup sort of moving around and irritating. This was one from Chris Palestro, did a very nice paper back in 2004, and I looked at his pictures here, and I would have said this I thought was going to be infected, and this was just a severe case of aseptic loosening, according to his paper. So I think you've always got to keep an open mind. There's huge overlap. This was one I just had recently, a guy who stumbled in the surf in Bali. He'd had it in for a few years. He got some hip pain. And if you look here, I wondered about the acetabular cup, but you look here, there's a little bit of activity here, a little bit of activity there, and a bit at the tip. This is about as subtle as you get, and that's why they're not easy. But they're the ones you're sort of trying to pick up. When I see that, I'm suspicious of that. He's got incidental cardiac amyloidosis. And you look here, and again on the SPECT CT you can see activity both sides of that calcar region there, and at the tip. And I think they were going to leave this guy alone because after trauma it may settle down, but I think he's just jarred that and loosened it. There was a technique of arthrograms. I should move along. We used to do where we injected colloid in and took pictures a couple of hours later, and you saw it get down in cemented prostheses. It shouldn't get down around the prosthesis. We thought it was really good. They stopped sending them. Maybe we were wrong. I don't know. But I thought it was really good. I think it probably should still be done. Not in the uncemented, so you can get stuff come down around the uncemented prosthesis. But hip resurfacing, you can get loosening there too. This is a Birmingham's. And on the SPECT CT, you don't see much at all on the planar, but on the SPECT CT, there was activity there. And if you thresholded it up, there was also activity around the peg there. And that was a loose one. Infection. Bones. We do bones and we do galliums. I've had experience in the past with microcolloid white cells, and I know there are people who really favour them. There's good data on Indian whites, but we don't do that much in Australia. I have no experience with PET and very limited experience with labelled antibodies. So the reason we do bone and gallium is because the infection's often chronic, and I think gallium is better for chronic infection. And also with the whites, you usually need a marrow. They've already knocked all the marrow around the place when they've put the prosthesis in. So it looks not like a native hip, but there's marrow patches everywhere. So you need a marrow scan to help interpret it. So then you're doing a bone and a white and a marrow, and I just think it's probably easier to do a gallium. PET may take it over. I'll come back to that in a moment. Well, I'll do it now. I looked up the literature on PET, and there's some cases saying it is wonderful, 85, 90% sensitivity, but 20% specificity. And there's others with 80, 90% specificity, 20% sensitivity. And it all just depends where you are on that ROC curve. If you're up here and you've got, wonderful sensitivity, but no specificity, you're not helping anybody. You're calling either everything or nothing. And so I think it's yet to be determined how good PET is. It may be great, but I think it's still to be worked out. Infection, I think the blood pools are critical. Like most infection in bones, usually hot on the blood pool, hot on the delayed, and often over the whole prosthesis, sometimes just locally. Another case, hot on the blood pool, pretty much all over. But the thing to do here is also look at the soft tissues. If you look at the asymmetry here, there's a big bit of soft tissue swelling there, and on the gallium, that was subsequently done to prove it, there's a great big abscess anteriorly there. And this one, it was a little bit of a funny area where the vascularity is. It's a bit lower and more medial. A bit on the delay, but a lot of soft tissue and a lot of activity against the ischial tuberosity there. Not all that impressive on the SPECT CT, but again, except you look in the soft tissues and there's this great big abscess between the ischium and the femoral neck there. So I think the SPECT CT can always look for the soft tissue components as well. Very briefly, metal on metal is a real issue. We're seeing more of them, and I'm sure everybody will for a bit. Frequently, the blood pools are very unremarkable. The delayeds, again, very unremarkable. But what you've got to look for is these aseptic abscesses. You can see there on that, and if you see that, and there's a metal-on-metal prosthesis in there, it's almost certainly particle wear causing aseptic abscess. Another one, this is one that had been okay for years. Now getting a little bit of blood pool activity here. The shaft's okay. The delayed bit of activity again up here on a diagnostic CT. The spec CT, hot in there. Not that much around here. On the diagnostic CT subsequently, she's got this change in here, and there's a stress fracture in there. But on the bone, there's this great big area here, which in the soft tissues, which the CT shows that, and that's another metal on metal. So you've just got to look at the soft tissues. Very briefly, heterotopic calcification is a problem. It's frequently down here around the greater trochanter. Very difficult, I find, to distinguish sometimes between heterotopic bone and trochanteric bursitis, unless they've got enough calcium, chronic enough to show it. Trochanteric bursitis, classically that sort of appearance. And lastly, hip pain's not only from the hip. This is actually a scan of my mother, who had a long history of trochanteric bursitis, pain over the trochanter after a hip that's been in about 5 years, had a bursal injection, no improvement, did a bone scan, and very unimpressive around the prosthesis, not much at all. On the delayed there, except for the sacral fracture, which he had about 5 months ago that the x-ray didn't show, but we knew it was there. And very little on that, but on the lumbar spine, hot left L4-5 facet joint, which one of my radiology colleagues injected. 2 days later, all the pain's gone. So always look SIs, facet joints, soft tissues around. Soft tissues, another one here, lateral hip pain. On the delayed view, you see the line of increased soft tissue uptake. On the spec CT, not much around the hip, but you look at the soft tissue windows, and the iliotibial band comes down there. This is sort of like the equivalent of trochanteric bursitis. There's inflammation coming down there, so always look again at the soft tissues as well as the bones. And finally, just a rarity or two. This one wasn't actually a hip prosthesis, but it had big trauma and a repaired pelvis with a whole lot of hardware in. And you see on the blood pool this hot early flow. They're very vascular blood pool. Not much at all on the delayeds at all. There's a lot of hardware in there, but not much in bony. And it doesn't necessarily project particularly well, but there's a swelling mass in there that's an aneurysm, a false aneurysm following the surgery. They, prang a vessel a bit and it forms it. Look, that I'll just skip through. The only other one to mention is that I've had 3 cases now where they've had back pain as well as hip pain. They've sometimes had pus taken out of the hip, but the bone scan shows uptake here, both sides of the joint. Gallium scan was hot on gallium, and there's a psoas abscess. And as the discitis tracks down the psoas, comes right across the hip there, and they can get secondary septic arthritis on native hips or prosthetic hips. And so, again, I always at least look at the bone scan. I've gone from a registrar to where I am now, and I still have enormous difficulty with these. They're never easy. You've got to use your judgment, and there's still going to be a whole lot you're going to sit on the fence with. This is one from just the other day. 8 months after a hip put in, blood pools, there's a little bit there. Delayed views, there's a bit around there, but for 8 months, that's probably acceptable. Maybe a touch at the tip. This a bit, but not all that much. What is it? I don't know. You can see it better there, a little bit at the tip. I thought maybe the tip was a bit of a worry, and you can see how they've changed these to the tapered one to try and get away from that modulus mismatch so that it flexes more with the bone. This is what she had in originally, and so that tip was like that before. So the tip's actually got better. But in the end of the day, this vascularity for 8 months, I like to see vascularity usually gone by about 3 months. I'll allow a little bit in the occasional patient, 4 or 5 months or so, but I think 8 months, that's too much vascularity. And my guess, it's a guess, is that it's an early infection. But that's why I say there's no science in this. I don't have any magic answers. It's just thinking about what the scan's like, thinking about what the prosthesis is like, thinking where the stress points are and trying to work it out from that. And the big other thing is communicate with your surgeon. If you get a good surgeon who gives you feedback, it helps so much in working out what's going on. Otherwise, you can end up like that. So.
Thanks a lot, Steve. That was a wonderful gallop. I had to remind you of a couple of housekeeping things. One is if you need CPD points, you should scan your QR code on somewhere around the door, I think it is. We better move on. I thought we might do questions at the end like you did yesterday, Steve, so the whole panel can answer your questions. Now, I'd like to ask Dr. Arun Parthipan, who's a staff specialist at the Royal Free, who works with Gopi, to do the next session. This is an impossible topic. It's SPECT-CT of the foot and ankle. I'm very keen to see what he has to say. I find it very complicated. Thank you, Arun.
Thanks. So yes, thank you for the introduction and for inviting me to speak today. I'm going to cover SPECT-CT in the foot and ankle and using SPECT-CT in problem solving in patients with foot and ankle pain. I'm going to take it quite basic and I'm going to cover quite a lot. I'm going to start off with some of the sort of simple things like the acquisition parameters, our reconstruction techniques. I'm going to go through the anatomy because I think the foot and ankle is a tricky area if it's something that you're not used to reporting regularly. And then I'm going to go through some of the pathology, the hind foot and the ankle, midfoot and forefoot pathology, and then finally just touch on some post-operative appearances in the foot and ankle. So this is taken from an older scanner, but this is essentially a sort of standard SPECT-CT protocol that we use. The SPECT component is fairly straightforward. I just sort of draw your attention to the fact that with the CT, what we did was we lifted the CT component from the diagnostic CT scanner. So we're using a 50 MAS acquisition, but we're not using any dose modulation on that. We're using thin slices, and we've got an overlapping pitch. The other thing we add in when we do a SPECT-CT is, so just like with the knees yesterday, I explained we acquire SPECT-CT images of both feet and ankles at the same time, but then we do a second reconstruction that's just of a smaller field of view of the particular ankle that we're interested in. And I'll show you why that gives you better image quality. The other thing to bear in mind is positioning. So in nuclear medicine, we're fairly used to immobilizing the patient for the SPECT acquisition. We need to make sure that there isn't motion between the SPECT and the CT so that we've got good image registration. But I think one thing that's not so well done everywhere is trying to maintain anatomical positioning. So if we're doing planar imaging, then just sort of taping the feet together or using something to keep the feet together is adequate. But when we're doing SPECT-CT, the feet and ankles, we want to keep the feet in an anatomical position. And there are lots of different ways you can do that, but try and maintain sort of that anatomical position and try and keep a gap between the feet. So this is an example of why using a smaller field of view reconstruction when you do your CT improves the image quality. On the left, you've got essentially a standard SPECT-CT with a large field of view. So what I've done is I've zoomed in on the detail that I want to see on the one foot. On the right is exactly the same scan, so we haven't done any changes to the acquisition. All I've done is I've reconstructed it with a smaller field of view just over the foot that I'm interested in. And you can see that on the image on the right, it's sharper. You've got less pixelation, and that gives you much more detail. And so if your surgeons or your clinicians are looking at those images, it looks like a standard CT. The other thing I think is quite important when you're doing your multiplanar reconstructions is to do them anatomically rather than a straightforward axial, coronal, and sagittal. So the axial, particularly when we're looking at the hind foot and the ankle, the axial plane should be in line with the ankle joint. When you're doing your coronal, you need to oblique them. So what I've done is I've selected a view through the through the ankle mortise, and you want your plane to go across the malleoli. And then when you do your sagittal obliques, they're basically perpendicular to your coronal obliques. This just helps you to orientate the ankle. And this makes all the difference when you're reporting, because it just makes it so much easier to see what you're looking at. And also the images that you present to your clinicians that are available on PACS is something that they can look at as well, and they understand what's going on. So I'm going to run through the anatomy. This is just aimed at sort of giving everyone a sort of brief overview. I usually just start off at the top and work my way down. So the first thing I look at is the top, the axial slice just above the ankle. You can see you've got the tibia, the fibula, and in between that is the tibiofibular syndesmosis with the interosseous ligament, which acts as one of the stabilizers. On the right, you've got an image which shows a corresponding MRI, and we can see a bit more on the MR. So we can see the tendons, the flexor tendons in particular, and you can see those on the CT, and sometimes they can appear thickened and give you an idea that there's perhaps a tendinopathy. Also, when I'm looking at ankle joint, it's worth having a look at the coronal image. You can see there that's a coronal image through the ankle. And this axial slice here this is a little bit lower down from the one I showed you before. And here you want to look at the malleoli and particularly the articulation on either side here. So you should have a nice, smooth articulation. The joint space should be nice and even on either side of the ankle mortise. Again, on that coronal image, you can see the tibia-talar joint itself, and on the medial side, you can pick out the deltoid ligaments, which are the medial stabilizers of the ankle. As you go slightly further down on the axial, at this level here, where you've got the concavity of the fibula, that's where you can see on the MR, you can see the anterior and posterior talar fibular ligaments, which are the lateral stabilizers of the ankle joint. Again, you can just about pick those out sometimes on the CT. And the subtalar joints are also commonly involved in pathology of the hindfoot. And I find those are best evaluated on the sagittal images. So you've got three facets, the anterior, middle, and the posterior being the largest. The middle facet is sometimes associated with a tarsal coalition, and so it's also worth having a look at that on the sagittal and also the axial images. Whilst you're there on the sagittal images, just bear in mind you've got the Achilles tendon coming in here, and this is the insertion of the plantar fascia. And so if you know where those are, you'll know why you get some sort of focal uptake related to those pathologies. So finally, we sort of move on to the midfoot. So if you're looking on the sagittal views, you've still got the talus there, you've got the navicular, the talar-navicular joint, and you've got the calcaneocuboid joint here. I find it's easier when you're looking at the midfoot, and specifically if you've got midfoot pathology, to do a different reconstruction. So this is in alignment with the first metatarsal. So essentially bring up the sagittal and then align your slices along the first metatarsal. That has the effect of opening up the midfoot. Suddenly we can see all the joints of the midfoot, we can see all the bones nice and clearly. You can see this nice sort of S-shaped alignment of the talus and the calcaneus. Allows you to count the cuneiforms, and sometimes you might have some congenital variants of that. In patients who have had sort of amputations of the toes and of the rays, sometimes you can miscount, so it's quite useful on this view to be able to see exactly what you're looking at. Also, just bear in mind when you're looking at the forefoot, the sagittal view is quite nice to look at the sesamoids. So I'm going to go through some of the pathology. I think it's worth, when you get your referrals from your clinicians, it's worth trying to kind of differentiate hindfoot from midfoot and forefoot pathology. The reason being, your reconstructions are slightly different for your hindfoot, and what you're looking for, the kind of things that you might see are also slightly different. So this is a typical example where we've had a patient who's had a previous ankle injury. They've had a traumatic injury to the syndesmosis. They've done an attempted internal fixation, and unfortunately the screws have fractured and they're getting an ongoing pseudoarthrosis. So we can see that there's evidence of instability with increased uptake at the site of the previous fusion or attempted fusion. There's also increased space there at the tibio-fibular articulation. So when we're looking at that, I find it's useful to look at both feet and ankles at the same time, look at both ankles, look on the axial view and assess that joint. You want to see that it's symmetrical, and you want to see that there's no widening or narrowing of that articulation. And unfortunately, a lot of these patients with ongoing instability, the endpoint is arthritis or secondary osteoarthritis in the tibio-talar joint. This is another example. This is actually where you've got osteoarthritis in a patient who's had a previous fracture. So osteoarthritis in the ankle is rare to be a primary pathology. It's often related to some sort of previous trauma. It may even be fairly mild or trivial trauma with some ligamentous injury, but can result in secondary osteoarthritis. In this case, what's happened on the SPECT-CT, we can see that there's erosion of that inferior screw through to the articular surface, and you've got uptake on both sides of the joint there. If you have trauma in the ankle in younger patients, the other thing to bear in mind is you can get small osteochondral defects. So if you're seeing very focal uptake, look for this sort of subtle lucency on the talar dome. The trick is this is only, you tend to only get uptake in the talar dome rather than on both sides of the joint. So this is actually an osteochondral defect rather than osteoarthritis. And in comparison, this is quite a severe case of infection, and you can see there's uptake on both sides of the joint, quite extensive osteolysis on both sides, and actually on here you can just about see this little dead bit of bone sitting within that abscess there. Whilst you're on those on the sagittal images, I find it quite useful to look at the posterior aspect of the ankle joint. This is an accessory ossicle, osteogonum, and they can often be associated with impingement syndrome. So in a patient who, if you've got repetitive flexion of the ankle, this can impinge and cause increased uptake. And in contrast, this is a slightly different variant. So as opposed to an accessory ossicle, this is essentially a fused ossification center. But again, you've got increased uptake there. So this is again causing similar pathology with impingement in the posterior aspect of the ankle joint. So you remember where we saw the insertion of the plantar fascia. So we can see very focal on the SPECT-CT, very focal uptake here in the calcaneus on the inferior aspect related to plantar fasciitis. And similarly, increased uptake here on the Achilles insertion related to Achilles tendinopathy. In these sort of cases, it's also worth just sort of, I don't have an example, but it's worth having a look for sort of convexities of the calcaneus, sort of sometimes called the Hageland's deformity, which may predispose to this sort of condition. I'm going to just sort of mention a few other sort of aspects, such as sort of impingement syndromes in the ankle, which are sort of slightly different from osteoarthritis. Here you tend to see sort of uptake around the sort of non-articular aspects of the joints, or the non-weight-bearing articular surfaces of the joints. So here you've got sort of medial ankle impingement, where you've got uptake around the medial malleolus and medial aspect of the talus, which looks very kind of osteoarthritic. You've got irregular joint space, you've got subarticular cyst formation, and the 3D volume rendered images show you that it's on the medial aspect of the joint. Similarly, you've got here you've got anterior impingement, where you've got sort of osteophytic overgrowth along the anterior aspect of the tibia. Can sometimes also be associated with a sort of a spur on the neck of the talus. And this is another example of medial impingement, but this is related to a small accessory ossicle adjacent to the medial malleolus. And in this case here, we've got quite a severe valgus hindfoot deformity, where you've got actually osteoarthritis here of the tibio-talar joint, but also you've got articulation of the fibula onto the lateral aspect of the talus, and also almost onto the lateral aspect of the calcaneus, showing quite significant biomechanical stress and arthritic changes due to that sort of valgus hindfoot deformity. So that takes us on to using SPECT-CT in assessing the hindfoot malalignment. So one of the things that we've been asked to do is using SPECT-CT in assessing flat foot deformities. So Whereas when we use MRI or ultrasound, looking at things like posterior tibialis tendinopathy in flat foot deformities, the advantage of using SPECT-CT is actually there's quite a good correlation with looking at the sites of uptake in the hindfoot and correlating those with the degree of sort of varus and valgus angulation. And also you can assess for other things like sinus tarsi compression. So this is an example where this is a patient who's got a flat foot deformity. They've got a sort of a valgus angulation of the hindfoot. They've had an osteotomy of the calcaneus, and you can see there's actually sort of some uptake here on the lateral aspect of the talus. So what's interesting here is this isn't related directly to the subtalar joint. It's slightly lateral to that. And actually, if you look, this is a similar sort of example where we've got sort of uptake here on the lateral aspect of the talus, but also along the anterior aspect of the calcaneus. And when you look on these nice sort of 3D rendered images, you can see that this sort of uptake is sort of outlining the sinus tarsi. So the sinus tarsi is a cone-shaped fat pad that sits on the lateral aspect of the foot there, and what's happening is obviously as the patient's weight bearing, they're having that sort of repetitive stress and the repetitive angulation of the foot, which is compressing the lateral aspect and the sinus tarsi and compressing the nerves and causing pain on that side of the foot. So when we look at the midfoot, one of the things that I always find that it's worth sort of trying to identify is for things like tarsal coalition. It can be really difficult. So tarsal coalition is a congenital fusion of the bones in the foot. It can be osseous, in which case it's usually easy to identify on the CT because it just looks like one bit of bone. It can be fibrous, and in which case it looks like a joint. But one of the things is sometimes the joint looks slightly longer, or the area of the contact is slightly larger, and often it's bilateral. So in this case, it kind of looks like maybe there's just osteoarthritis, but it's very focal. It's an irregular shaped joint, but then when you look on the other side, you've got a similar appearance. So this is a tarsal coalition. Sometimes you get avascular necrosis, and the navicular is a common site for that. You might see some diffuse uptake in the navicular. The end stage is this sort of collapse of the navicular with loss of height, and then secondary osteoarthritis as a result. When we look at the forefoot, one of the more common things that we see are stress fractures. Plain films are a good starting point. So you could just about make out, you probably can't see on the screen, there's just a little bit of fluffiness and a periosteal reaction, which was actually missed in this patient. But when we did the SPECT-CT, it's very easy to see the sort of focal uptake. And again, the CT shows up the subtle periosteal reaction more easily. So this is a clear-cut case of a stress fracture. You also get avascular necrosis of the metatarsal head. So this is a fairly advanced case. So again, with avascular necrosis, you might get uptake on one side of the joint. Here you can see on the CT there's flattening of the metatarsal head, and again secondary osteoarthritis as a result of the sort of progressive degenerative changes. This is an interesting case. This is a patient who's had an obvious fracture of the base of the fifth metatarsal a long time ago. This is their plain film, and the surgeon was sort of saying, well, it's obviously ununited. Before they wanted to take them to theatre, let's do a SPECT-CT to see what else is going on. So obviously we can see that this is an ununited fracture of the base of the fifth metatarsal. We don't need any other imaging to diagnose that. But when we did the SPECT-CT, we could see there's obviously this ununited fracture, but there's also osteoarthritis of the fifth tarsometatarsal joint. And this is invaluable information because in this case, the surgeon went on and actually did a fusion of the tarsometatarsal joint as well as the internal fixation of the base of the fifth metatarsal fracture. If they didn't have that, if they just relied on the plain films, they may have just done this and then presented again with pain in the base of the fifth metatarsal. And finally, I'm just going to go through some post-operative changes in the foot and ankle. This is, I think, where we find SPECT-CT is hugely invaluable. because of the metal artifact, you can imagine that an MRI is not going to be much use in this kind of case. CT can be useful, and here you can see sort of serial slices through the coronal slices through the SPECT CT, and you can see that there's sort of uptake here around the joint, but you can see quite clearly as you cut through that there's a persistent lucency. So this is, you have no idea what's going on these plain films, but you can see very clearly that there's a pseudoarthrosis with an incomplete union of the ankle internal fixation. I'm going to finally show you it's an ankle replacement. This is not a common procedure, but it is sometimes done in younger patients where they want to try and preserve some mobility in the ankle joint rather than do a fusion in a patient with severe arthritis. We've done a few SPECT CTs in patients like this, and what we don't tend to see is loosening or infection of the prosthesis like we do in the hip or the knee, but we often see these kind of appearances where actually you've got an impingement syndrome. So you've got sort of focal uptake, which you wouldn't really appreciate just on the CT on its own. But again, adding the SPECT component, you can see that there's sort of focal uptake there. You've got overgrowth of the medial malleolus and impingement there on the medial aspect. So again, this is a very useful technique, SPECT CT, which I don't think you can really get this information from any other imaging modality. So really, just to summarize, I think it's important when you're doing a SPECT CT just to make sure you get good, high-quality images with isovolumetric reconstructions. I'd encourage you to reconstruct your planes according to the ankle joint or the midfoot. So you do need to encourage your referrers to be a bit more specific about whether it's ankle or whether it's foot pain, and then protocol your scans accordingly. So we're sort of training our technologists to be able to sort of reconstruct according to hindfoot and ankle versus midfoot and forefoot. Try and use the small field of view reconstructions. It really helps just get much better detail when you're looking at the CT of the foot and ankle, and for any extremity. So we use the same for the wrists. When you're looking for things like tarsal coalition, check the other side. And I think also using the 3D volume rendering, particularly in the foot and ankle, is very useful because it allows you to see the sort of biomechanics and the sort of 3D evaluation of the foot and ankle. Thank you very much.
Thanks, Aaron. That was a great approach to a very complicated area. Bare territory. The next speaker is from Glasgow. He's from the Glasgow Infirmary. It's Dr. Sai Han, and he'll be talking about an approach to the indeterminate bone lesion with SPECT CT. Also a complicated area. I'm looking forward to this. Thank you.
Thank you, Mr. Chairman. Good morning. Still morning in Glasgow, 2 a.m. now. Okay, so it's a little bit general, bone SPECT CT in indeterminate lesions. Okay, so learning points, very basic, why we need SPECT CT. When we doing that, and just briefly what to look for, and how we do it. As Steve mentioned earlier, it's more subjective approach, but hopefully it's useful for younger trainees. Bone and nuclear medicine is still a standard of care. Yeah, a good old bone scan, many years, but still in the guidelines, clinical or research, because it's whole body. Yeah, whole body MR coming, but it's not available all over, and it's very sensitive. So we should improve bone scan. Yeah, it's a workhorse of our nuclear medicine department. Oncology, rheumatology, orthopedics, and sports medicine, as you already heard. Okay, so why nuclear medicine? Just a few cases. Example, yeah, prostate cancer, very common. Bone scan, very good. In research as well, a lot of research trial, bone scan is still one of the marker. Okay, so on CT, very subtle, nobody will report, but you can clearly see black and white bone scan. And even in breast cancer, yeah, lytic lesions, bone scan not good, but some bone marrow lesions, MRI the best, but bone scan is better than CT or X-ray. So bone scan still play a vital role in a lot of tumors. So bone scan very good, planar, very easily available. But so why do you need bone spec CT? More radiation, more expensive, time consuming, because although it's whole body, easily available, highly sensitive, well-established technique, it's not perfect. Yeah? It's very sensitive but not specific at all. And no anatomical localization, very poor characterization, and you will request a lot of further radiology tests, and then clinician will be frustrated. We send something, and then you have to do another one, and radiation as well. Okay, so just a few cases. Yeah, breast cancer, very common. A lot of lytic bone mets. So both can be problem. So Who Wants to Be a Millionaire? It's a popular series in UK. Yeah, so this case, very hot breast cancer. So will you go for bone mets or request further radiology, or just ask residents? Okay, so we did SPECT CT. What we found was it's behind a SPECT scan. It's behind the iliac body on the right side. So is it soft tissue? Is it still, what's that? So SPECT CT clearly shows contamination. So if you ask for further radiology correlation, you'll be in trouble. Yeah. Okay. So adding CT to bone scan, you already know there are a lot of improvement by adding SPECT CT in orthopedics. We had a lot of things. I think localization is probably very important in smaller structures like foot and ankle, hands, something like that. But big skeleton localization is not that important, but characterization, even though we use low dose, unenhanced, yeah, very poor quality non-diagnostic CT, is still okay to characterize many cases. So increased specificity, and we can even see the soft tissue mass, so very good, and increased diagnostic confidence. Main thing is less indeterminate scans. Yeah, that's the main thing, and then for that you get a shorter time to treatment. But issues, training, yeah, radiology. Even though we are nuclear medicine physician, we need to learn radiology, and we need to work with MSK or general radiologists as well as MSK radiologists. Scan time, that's a main issue because SPECT takes at least 10-20 minutes depending on the time per frame. So that's protocols, things like that. So we need a faster scanner, yeah, and radiation as well. So a few evidence. I just found out a very powerful article just published this year. Is in total knee replacement from Europe. So it said by using SPECT CT bone scan, it saved a lot of money. Yeah, it's compared to CT as well as MRI, metal artifact reducing sequences. Yeah. So other thing, this is from Asia, Malaysia. Yeah, breast cancer bone SPECT CT is much better than planar bone scan or SPECT by reducing equivocal results. This is from our own team. We presented in SNM. By using bone SPECT CT in breast cancer, we reduce inconclusive results significantly. So that's very useful. So I think SPECT CT is the key component in bone imaging. And this is from India. Why SPECT CT is very good? Because of CT. Yeah? CT alone or SPECT CT is much better than SPECT. So we need to improve in CT aspect from SPECT CT. Okay, so I have convinced you SPECT CT is very crucial. So when we use SPECT CT, that's very variable. Yeah. So are we going to do everybody that won't be popular with the staff or manager, or are we just using when required? Yeah. So what I think useful is we need to check all the clinical data, all the imaging, and then check is diagnosis is conclusive. So I think majority will do that. If not inconclusive, if not conclusive, we'll go for something, whether radiology or SPECT CT. But I would like to add one more thing. Is severity conclusive as well? Yeah. If we know the diagnosis, but if we can give a little bit more on the risk, that would be even better for the patient. And majority will do SPECT CT if abnormal or inconclusive planar imaging. But I would like to propose one thing. If scan is not much, but if there is significant symptoms, will you do SPECT CT? I think we should, but it's a bit controversial. So whether routine or PRN when required, what we do in prosthesis look like very important in foot and ankle, hips, yeah, TKR, evidence-based, cost-effective. And we just learned whole body SPECT CT talk yesterday in the technology session. So are we just doing whole body SPECT CT instead of planar? So that will be similar to PET CT. So a lot of things to consider. So just to give you one example, CT, very clear, very high resolution, beautiful, but negative. So came for bone scan. I don't know what they're looking for, but bone scan seems okay. Yeah? But technologists ask the patients, but complaining of severe pain. So what did we do? We did SPECT CT. Yeah. So will you send away a normal bone scan home? No. Think about patient as well. Yeah. Or you can. Do you want to just do CT? X-ray might not show up. So SPECT CT useful, and then we can call the clinician because it's an aggressive lesion in the upper thoracic spine, infecting the spinal canal. That's critical. Yeah. Okay. So what are we going to look at in the bone imaging? Main thing is location and then characterization. So in the one paper, recent paper, what they found out was there are a lot of things they break down into 6 patterns. Yeah, main thing are, is it because of location, for example, non-skeletal, contamination, incidental stuff, or usual pathology, malignant, injury, trauma, degenerative, or primary bone tumor. That's we need to think about as well. And inactive mets, things like that. So how are we going to find out these things? So I think 5P, just to my quick review, all P. Yeah? Number one, we look at the planar imaging very quickly, and then we decide what to do. But check patient info as well. Technologists need to ask whether there's any recent procedures, recent infection, trauma, yeah? Pain, very important. Yeah? And then we briefly need to look at other imaging, nuclear medicine, as well as X-ray, CT, MRI. Yeah? Because sometimes we can highlight area to look at. We can target the review. Yeah? And then you can decide whether to go for SPECT CT or not. And main thing is you need to play CT. So very good earlier talk. Yeah? So we need to learn from that. Okay, so how I do planar, check. So similar theme, yeah, very easy bone scan, very abnormal. People will say 30 seconds bone scan report. Widespread bone mets, goodbye. Or will you just do usual, think about spinal mats? Will we go for MR? Okay, you're reasonable, but that will take another week, 2-3 weeks, or months. Or shall we do SPECT CT? Yeah, we should. So this one, another malignant spinal cord compression. So you need to call the clinician. You need urgent fixation, radiation, things like that. Okay, so need to check patient info. Good history, you never get good history. That's okay. So we have nurses or junior doctor can get the clinical info. Very good. One example, this case, esophageal cancer, back pain. So radiology will just do spine. Yeah, but the problem is not the top pain, but low-end pain. So it's a pelvic pain, but patient just say back pain. Yeah. So that case came back, bone scan. So is it Paget's or is it METS? Okay, we can quickly do X-ray, or if you don't have, you can do SPECT CT. But SPECT CT much better. You can get the aggressive lesion, associated soft tissue mass. Yeah, so that's very good. So need to check previous imaging. One example, this case, lung cancer with back pain, recent CT was fine. Yeah, nothing. Okay, so CT fine. So we came back. It came back to us. Technician said back pain. So we look at the recent CT. Nuclear medicine physician looking at the CT. So a little bit problematic, but no problem. We have the same team. I work in lung MDT, so these are all friends. Okay, so look at that. Yeah, so irregular cortex, a little bit of soft tissue in the transverse process, upper thoracic spine. So I just spoke to the radiologist. Hi, this look very aggressive. So I agree. So addendum to the report. So that's sorted. No need for SPECT CT. So we need to look at the old CT. Okay. So SPECT CT, how we do it is very variable. Yeah, different department do different things. But main thing is CT. So don't take too much time doing SPECT. That's the main thing. Because in older guidelines, maybe 20 seconds, 30 seconds, something like that. So I think 10 seconds should be okay. Maybe 8 seconds, something like that. Okay, so main thing is play with CT. So we are used to looking the whole thing in very small area, whole body bone scan. So never do that in CT. CT need large view. So use the whole screen, try to look at everything. Yeah? Need to be systematic. Start by top to bottom or bottom to top, or most important area, go up and down, things like that. But just form a format so that easier in the future. So get appropriate windows. Just bone scan, okay, let's just check the bones and then done. No, you need to look at soft tissue window, lung window. Yeah, there are a lot of things can be found. And multiplanar reformat, that's very important. We already heard about ankle. So everywhere, like spine, sagittal, very good. Yeah, things like that. So axial, sagittal, coronal, need to play CT on Park's machine. Okay, so just one example, yeah, multiplanar. So sagittal, you can see the sternum, lytic mats in the spine, things like that. Yeah, transaxial, so you just flip through. Okay, so morphology, characterization, very important, even though it's a limited CT. So main things are location, how many are there, density, is it sclerotic, lytic, or mixed. Aggressive features, that's very useful term. Yeah, and you just say aggressive or non-aggressive, and then think, depending on the clinical info, whether it's tumor or infection and things. So just to remember, not all hot stuff are disease. Yeah, the same thing, not all sclerotic or lytic lesions are malignant. So hot sclerotic doesn't mean METS. Okay, So there are a lot of things. There are a lot of mnemonic, Ventigate, home life. So I will suggest you read something easier, Radiopedia. Okay, no problem, quick, or Google. Yeah, or there are a lot of articles as well. Yeah, so no problem, very useful. But common things like bone island, sclerotic. No, there are a lot. We got a lot of requests. CT shows sclerotic lesion. Is it METs? Cold on bone scan, bone island, things like that. Endochondroma, bone infarct, things like that. Heat fracture and chemo response is one area because CT start with lytic mets and then healing cause sclerosis. Radiologists will say bone mets, bone scan hot because it's chemo, flare response, things like that. So need to be careful. Sometimes time will tell. That's the main thing. And other tumor like lymphoma. Okay, so lytic bone lesions, that's what there are a lot of lytic. Yeah, lytic doesn't mean malignant. Yeah, fog machines. Yeah, there are a lot of. So okay, I just skipped through very quickly. Yeah, so too many things. So you can remember that article, 6 patterns, or these what I have seen in relatively more than others. So OA, like degenerative joint, small node can be mistaken as lytic, but it's just benign things, joint space, things like that. Is it infection? Is it degenerative bone mets, fracture, fibrous dysplasia, things like that? Yeah. Okay, just a few more cases. Prostate cancer. You can see 2 hotspots in the pelvic, quite white. Okay, so you can see hot, irregular sclerotic lesion. Yeah, you may say bone mets, but that's been there for 5 years. So that's enchondroma. But the hot one at the upper butt, in the left iliac body, is a new one. And sclerotic pattern is more diffuse, ill-defined. So that's bone mets. So without SPECT CT, you will be just saying all bone mets, things like that. Yeah? And the same case in the skull, hot, in the occipital area, lytic, like a ground glass pattern. It's fibrous dysplasia. Yeah? Hip pain, differential diagnosis of the sclerosis, Paget's disease, bone infarct, AVN. CT can show up irregular subinguinous border sclerotic lesion, things like that. Yeah. And Paget's disease on the right iliac, thick, ghost trabeculation, things like that. These are very common in bone scan. This case and Paget's, like a Honda sign on nuclear medicine planar imaging. And the CT, you can show thick margin, ghost trabeculation, and can be hot. So don't be mistaken as METs. And as already mentioned, chemo response can be difficult, hot. It's not very diffuse, some areas a bit scattered, so is it METs? But same treatment, 3 years down the line, more sclerosis is response. One case, lytic, X-ray show lytic lesion in the medial, inframedial aspect of the left femoral head. So MRI the best, but MRI patient was claustrophobic, so came for bone scan. It's hot in the left femoral neck. So 2 and 2 together sounds like METs in breast lump. Actually, we did SPECT CT. That's the one lytic lesion is actually degenerative cyst, lucent area, juxtacorticular with sclerotic margin. Cold on bone scan, called geo, large one. So not bone mets. So why it's hot? Because it's the fracture, linear lucency in the left femoral neck. So that's very useful. So patient need pinning or prosthesis, this case, prosthesis. Hemiarthroplasty, I just learned earlier. For fracture. So aggressive lesions, you can learn from books. Zone of transition, narrow zone of transition is ill-defined. Yeah? A soft tissue mass, that's easier to see in CT. Periosseous reaction we've seen earlier, like fracture, things like that, or mets. Okay, one example, aggressive lesion, lung cancer, painful chest wall. So one of the ribs is irregular cortex, associated soft tissue mass, pathological fracture, aggressive mets. Already shown, yeah, the dorsal spine, posterior element, pedicle, destroy, soft tissue mass invading the spinal canal, and sternum as well, or aggressive. Yeah. So a little bit more cases, benign cases, so osteoporotic fracture in the upper lumbar spine, and then a lot of stripes, so it's hemangioma. And then there's one in the lumbosacral, S1, lucency with sclerotic rim. Oh, is it METS? It's a degenerative Schmall's node. Yeah? So these can be seen in PET as well as SPECT CT practice. So one case, very interesting. So SPECT CT doesn't solve all the problem. We reduce the indeterminate lesion significantly, but sometimes still inconclusive. So what do? I check with MSK radiologists. So we have very good relation. Useful. This case, yeah, pancreatic mass, CT pelvic, chest abdo-pelvic show sclerotic lesion in the left iliac crest. Very irregular, yeah, narrow zone. So bone scan, hot, a few hot spots, not quite sure. So I look at the CT, very sclerotic, irregular. So we check with MSK. Okay, so mid-lumbar spine, we already seen earlier, is a facet joint, no problem. But why that one is hot, not quite sure. So requested MRI, MSK. MSK have two tools, yeah, but maybe three. One is ultrasound, two is MRI, three is biopsy. Yeah? If not, right. Okay, so this one, they wanted to do MRI, but patient didn't attend, yeah, DNA. So, okay, no problem. And then a few months later, came back, normal. So no tumor, nothing. So what's that? Just fracture. Yeah, so just sometimes healing fracture with irregular sclerosis, you don't see the fracture line, so be careful, yeah, this case. Okay, so sclerotic hot lesion can be healing fracture. So just quickly run through the incidental finding. That's why we need to be systematic, check all the windows, yeah? So depend on the region, yeah, chest, abdo-pelvis, neck, head, yeah, you can pick up a lot of significant things. That one, lung cancer. This one, degenerative joint disease, facet joint, lumbosacral junction, but a little bit hot in the right upper quadrant. That's a typical exam question. So soft tissue uptake in bones imaging. Yeah, so this case turned out to be hepatocellular carcinoma. This one is not that clear, but not clear on bone scan, but on the SPECT CT, the right renal mass, difficult to tell, is it just cyst or solid? So just check Hounsfield unit, yeah, it's solid stuff. So need to raise, so diagnostic CT, renal cell cancer. Prostate cancer imaging, useful. Pelvic SPECT CT, don't just look at the bone, look at the soft tissue, you can see relevant pelvic or para-aortic lymphadenopathy, useful. Okay, so summary. So a very simple thing, why we need that, when we do that, what and how we do that. Yeah? So just to remember systematic reading, play with CT, 5P. Yeah? So not all cold stuff are good and not all hot stuff are bad. Yeah? So sclerotic or lytic lesions have wide range of differential diagnosis. And love your team. Thank you.
Wasn't that the quirkiest talk you've ever heard? I loved it. Now, what we might do is get the whole team up here, and I'm very happy to take questions, nice ones preferred. And if you could just walk up to the microphone, please, so that you can be recorded for perpetuity. Thank you. All right, oh, by the way, Steve Allwright just made a really interesting observation. We should really be publishing this stuff in the orthopedic and oncology literature. There's no point publishing this in our journals because nobody else reads our journals. I think Steve made a very good point, and we should try and practice publishing this in our referrers' journals. Thank you. Please.
Just to introduce myself, my name is Alexander Kreuz from Innsbruck in Austria. I also work on SPECT-CD on both for oncologic and orthopedic indications. The first thing I have to say, I really thank you from the heart for these excellent talks to each of you. I think it really deserves an extra applause. One of the best sessions. Just some additional comments. I totally agree with you. We can increase the specificity in both oncological and orthopedic SPECT-CD indications. So from my personal point of view, if I talk with the patient regarding the anamnesis, for instance, for trauma operation indications, I really step on it to say not just recent trauma, but also trauma from the past, and also regarding for operations. I really focus on that because I really have the feeling that it really increased the specificity, although I have to say I shouldn't forget to inject the tracer to start the imaging of the wounds. And the question I've got to Stephen is, at our department, we use a software program for the quantification for the knee, for prosthesis of the knee. It's like a software provided by Hermes. So it really helps the referring physician to cope with the number of activity, if it's like due to postoperative changes or to loosening. And I want to ask you if you also use that program or a similar program.
We don't have any quantification. I might throw that over to Aram, who gave a very good talk on knee prostheses yesterday. Do you?
Yeah, no, we don't have any quantification software. I don't have any experience of using that.
I mean, most of the literature is indeterminate about that. For every 2 papers you have that say it helps, you'll find another 3 papers that says it's rubbish. And I've tried to analyze this too, and I can't get any sense out of the literature. I think it depends on how much you believe and how validated what you do is. And I don't know, Steve, you've probably had the same thing. I've been asked this by the orthopedic surgeons, and we've tried it, and it ends up, after a couple of months, they forget about it, and so do you. So, I mean, if you've got good evidence for that, I'd love to see it.
Okay, I'll stick on that.
Okay. I must admit, quantification in nuclear medicine, I have this great ambivalence in that I think it's a really good idea and that we should quantify things. I think it's great from a scientific point of view. But time after time after time, I come back to mild, moderate and severe. And it almost is as much help, a mild stress fracture gets better in 4 weeks, a severe one might take 12 weeks. And I'm not sure that saying that there's, 40% or 60% necessarily helps, except in possibly the research sphere where I think if you can then prove that, a 60% took 12 weeks, maybe that's useful. But day-to-day clinical, I've always struggled a bit with quantification.
Okay. Thank you.
The main problem with quantification packages is most of the studies which come out is a single center study. And before launching any quantification packages, the industry makes the mistake they don't do a multicentric study to validate.
Yep.
And the third thing is it's quite expensive. There's no point doing quantification. I'll stick to mind moderator. It is expensive.
Yep.
It is very expensive unless you have a good amount of referral. There's no point in buying a quantification package where you do about 2 or 3 scans a day. It doesn't make sense unless you validate either through a national body, validate the scores, and it has to be done in the same protocol. First thing is we have to standardize the protocol because everybody does different things. The beauty of nuclear medicine is we do the same thing in different way, but still we get a proper quantification value will be the same. Whether you do whatever you do, you give a same quantification value, which doesn't make any sense. So it has to be validated before.
Could I add one thing? In PET-CT, same thing, yeah, SUV. Clinician think 2.5 equal benign or malignant, but I think quantification may be okay for changes assessment, but for diagnosis, it's just the probability rather than black and white binary thing.
Just a quick question. Uday Alawali, a nuclear medicine physician from New South Wales. Just a question for Aaron. With the ankle, you had reconstructions for CT in the plane of the foot that's physiological. With our spec CT packages, the CT component is limited in that we can't manipulate them. There is a reconstruction, but the coronal and sagittal planes are fixed. It's just what you see on the workstation. The technologists can't manipulate them unless you buy a license. Is that? Do you have that issue at your centre?
Yeah, so I've worked with scanners that on your when you do your initial reconstruction on the acquisition workstation, you can't create a reconstruction that's angled. But in that situation, there's usually another software or processing software that allows you to do some sort of reconstruction. So, for instance, I mean, there are sort of third-party software that's available. I mean, we use Osirix as well, which is a open source software that's available on Mac that does sort of reconstruction, so you can angle the CT in the spec CT. So there are ways around it.
Uday, if you're using Siemens, which I suspect you are, there is a protocol workflow you can do where after you've done your initial reconstruction, you use basically the brain technique, and you can go and change that in any plane, recenter and change it. I can send you the workflow up, but you've got to have small slice, so for peripheral joints, hands and feet, ankles, that small slice, 1 millimetre slice. Otherwise, you've got these horrible looking CTs that are stepped all over the place. But if you've got narrow slices, it reconstructs quite nicely. And so, like your pictures of the feet, it's lovely to bring up the metatarsals and the tarsal bones all laid out. You can bring them up this angle, twist it to that angle to correct for some of the problems in acquisition if they're not straight on acquisition.
Uday, if you remember, the original Gates paper in the late 80s, the guy used the cardiac software to slice up stuff. And it's fiddly, but you can do it on most of the GE systems as well. But it is very fiddly.
It's often good to do it as the doc yourself, though, because I find the techs often aren't good at knowing what angle that you want to see what you're trying to show. And so it's often quite good to just go in and get on the processing terminal and spend 5 minutes to get it just how you want it.
I don't understand that. Why don't techs know what he wants?
Not all techs, no, don't get me wrong. I'll get stoned on the way out there.
Can anyone comment on these new artificial intelligence programs, one that Siemens brought out to sort of tidy up bone scans and fit them to the CT? Are they useful, or has anybody had experience with them?
I haven't used them in clinical practice, but I've seen the sort of the Intivo systems or the Expert and stuff. I think my initial experience, I don't know if someone's using them in clinical practice, they may have a different opinion. I think they produce very nice images. And the idea is that the SPECT localizes much better to the bone, Whether it makes a difference or not in clinical practice and how it alters your diagnosis, I don't know. The other thing is you get artifact from when you've got a prosthesis. It creates artifact because what you see is you get the streak artifact on the CT, which then translates into the SPECT as well. So because it sees the CT, sees the streak artifact and the shadowing on that, and it thinks that there's no bone, so you get an artifact on the SPECT. So it might also have a sort of detrimental effect.
Has anybody actually read any literature on this? Because the only artificial intelligence stuff that's been published, as far as I know, is on lung scanning.
I was at a talk just recently, and on CT, it's definitely coming. CT of chest lesions, it improved the accuracy quite significantly over even experienced reading. You still need a reader to go back and sort of sign off on it and check it, but they found that it improved it significantly, and I think we're in the very early days of it. I haven't seen it used in nuclear medicine. I think fusion is going to be difficult because you're trying to fuse two different intelligent things, but I think big data, I think it's coming, and I think it will be a boon to us, a bit like looking at a bullseye plot. You know, half the bullseye plots I disagree with, but at least it makes you go back and look for what you might have missed. If the intelligence system says, you know, there's something here, you can go and check it.
Only thing is, do you think we should stop doing whole body bone scan and move towards whole body SPECT-CT?
Yes.
Yeah, good question. Because radiation dose, you get a lot of radiation from CT, whole body. So unless you can significantly reduce the CT, other thing is depend on the patients as well. Is a young patient? Things like that we need to consider.
No, because the data from Haifa, Israel, you can do a whole body CT in 30 minutes, whereas if you do a whole body and a SPECT-CT, you're going to do it for 45 minutes. So ideally, we should follow the HCT protocol, grow from head to mid-thigh.
So, Gopi, was that with a normal, 64 slice acquisition or 128 slice acquisition?
64.
64.
But still, each volume will take about 10 minutes, 9 minutes. So by 28 minutes, they can do a whole body bone scan.
Wow.
And that is more than sufficient. In terms of radiation, at present, each volume will have 3 to 4 millisievert extra. But if you're doing a CT for each area, because most of the patients will be screened. So if it's a breast cancer patients, ideally they get screened anyhow with your chest, abdomen, pelvis. So if you combine with the whole body bone scan, which is about 3 millisievert, plus another 6 to 7 millisievert, but whole body SPECT-CT you can do with 10 millisievert, which is still lesser than your conventional CT.
Probably if oncology cases, but for other things like orthopedic or rheumatology may not be well. So can be streamlined whether this patient clinical info is important to have whole body assessment.
Can I ask you though, I mean, one of the things I see on the MET screen sometimes is you look at the MIPS and there's something that looks bright in a rib, but you go back and you look at a planar and oblique of the rib and you go, oh really, is it there? I mean, my only worry is, are we going to overcall and undercall some things, or you're saying we do a whole body and then come back and do a planar of an area of interest like a rib if it's equivocal?
Rib is always a problem, whether you do SPECT-CT or PET MRI. Those are the areas where you get your equivocal scans. Even in at scapulae, the ribs are most problematic. You have to look for all these costochondral degenerations because you're moving from planar imaging to SPECT. It's like doing a fluoride scan. You're going to pick up a lot of things, but you have to give a meaning to it. For example, if you do a fluoride scan, you're going to see every patient will have rib fractures, but it's not fractures, it is just muscle insertions. So unless you have that in mind, you're going to overcall by doing a SPECT-CT because there's a huge learning curve. You're going from a planar to a dimensional, you are increasing a spatial resolution, you're going to pick up a lot of things which have no meaning in terms of your CT bit. And you should not mistake that for a marrow changes, which is again wrong because the teaching is if you don't see it on the CT, probably marrow, but it's not marrow, it is all just insertional enthesiopathies all over the body.
Thank you. We might draw that to a close if no other statements. And just thank the speakers, please. And also, could we thank... Could we thank Gopi, please, for organizing this? It was a fantastic thing.